Hello, everyone. So we're very happy to be here. My name's Jim Bialik. I'm the CEO of TrustedRide Certified. We're the access layer for an independent life. So what we do is we schedule and dispatch certified mobility companions who never leave the patient at the curb, staying with your loved one from home through care and then safely back again. So we have 6 years of experience, 28 sites in 18 states, but we were built first inside of a nonprofit, and now we're scaling through a commercial platform. Transportation options have expanded dramatically. Access has not. Transportation ends at the curb. Care does not. Healthcare breaks down in the handoffs between the front door, the vehicle, between the curb, and the exam room chair. Our model ties the labor, the accountability, and the payment to the client instead of to the vehicle or mode of transportation. So what's the problem? Rideshare can leave a chemotherapy patient at the curb in the rain. Healthcare system still counts this as access solved. 3 populations hit this wall. Hospitals, $150 billion a year in missed appointment costs. Clinical research, 1 in 5 phase 3 trials failing on retention. Aging in place. California nursing homes are projected to be at capacity in most major regions by 2030. So here's the proof of our success so far. This is 6 years inside 501c3. At Ascension St. Agnes Hospital in Baltimore, our third-party evaluated pilot completed 1,501 appointments at a 92% adherence rate with $309,000 in documented savings. 28 sites, 18 states, $7.5 million in non-dilutive federal funding. First-in-kind 5-borough contract with New York City's Department for the Aging. So this is what's changing. The market is pulling us into commercial infrastructure. Hospitals are asking for commercial-grade access, pay-for-value and new payment models. CROs need participant retention. Aging networks need accountable accompaniment. Our nonprofit provided the model. The LLC is what is being used to scale this infrastructure. So nobody else in this room can show you 6 years of nonprofit proof becoming a for-profit platform. Here's how the model pays back. There are 3 lanes. There are 3 named buyers here. Hospitals see the opportunity in shared savings arrangements. They're tied to reduced missed appointments, readmissions. Ascension St. Agnes in Baltimore, every dollar spent returned $1.91. Clinical research organizations are engaging us because the cost of continuity is negligible when you compare it to the cost of having someone drop out of a trial, especially in phase 2 or phase 3, which is delaying enrollment. Aging networks and community organizations are paying to ensure that older adults have safer, accountable accompaniment through care, and that caregivers have peace of mind. And sometimes caregivers get a break, too. It's the same platform. It's three buyers, and they all have aligned incentives. So the competitive landscape here, the moat, is that rideshare moves vehicles. We move with the client. It's a different labor model. It's different economics. Coordinating accountable accompaniment across fragmented transportation is operationally very difficult, and that difficulty is the moat. Most pitches that you're going to hear today and at a lot of other places like this are great ideas that are waiting for proof, and we're sitting on 6 years of proof, 18 states, and we're ready to scale. So here's the ask. $300,000 to complete the transition from proven nonprofit model to scalable commercial infrastructure. It completes our Trusted Riders app. It allows us to do multi-buyer billing and rapid deployment integrations. It's not staff capacity. We already have the workforce. This is the capital that turns our 6 years of operational proof into the commercial-grade infrastructure for clients and the loved ones that can't get there alone.
I'm going to cut off there. Thanks very much. We have any questions from the judges? Thank you.
Thank you for sharing. Can you talk a little bit more about the workforce?
Sure. So we have several different workforce models that exist in the 28 sites. So it ranged on the front end with volunteers that were in hospital settings. That was the very first way through. And then most recently in New York City with our 5-borough pilot, the way that has worked is we actually have coordinated with New York City's workforce programs, and they are a feeder into the system or into the program that works citywide. Community-based organizations have been a huge source of originally volunteers, but now paid trusted riders as well. It's a neighbors helping neighbors component. And a large part of our footprint is in the village-to-village network for aging in place. And so that has a really built-in community of individuals that are looking to support those villages as well.
And a follow-up question, can you talk a little bit about the actual vehicles? Are the workforce the drivers, and then are you guys owning the vehicles, or can you talk a little bit?
It's a great question. We are not the wheels. We do not do transportation at all. So if you want to use rideshare, if you want to use the subway system, if you want to walk, all of these things, we provide a mobility companion that goes with the person door through door for that part of the trip. So we're a layer on top of all that.
Great concept. So you are the only team that does have 6 years of experience. Where were the pitfalls in the 6 years?
So I'll tell you, one of the most interesting parts of this has been that when we first started out was heavily based in federal grants and community care corps grants that didn't exist really before we had gotten started. So some of the easiest pitfalls have to do with federal granting. And then the next part is that when you're looking at the partners through different hospital systems, everyone is different. Everyone has a different way of managing not only their transportation, but managing their volunteer force especially. And so what we've seen is that over the 6 years of the 28 installations, there are some common themes. And so we're not quite to trusted riders in a box where you would have one solution that's perfect, but we're pretty darn close when it comes to what the technical components are required to do that. So the demand is the same. Everybody sees the issue and can identify with the issue of having cared for somebody either that is that's aging or somewhere at risk. We hear a lot from the autism community as this is another source that this would be really valuable in. And so everybody says this is a great idea, we want it at our place. And then we go to their place, they're like, it's totally different than what we've seen before. And so that standardization and the certification in our training, the training is consistent. The technology is consistent. The implementations are all over the place, but the level that we're delivering stays high.
Okay, I'm going to have to end it there. Thank you very much.